my views on the alectinib data are the median progression-free survival is over 2 years, and it has good activity in the brain, and as mentioned, has a very good tolerability profile. So I understand the importance of the sequencing issue, but I think that the ability to have a patient on a well-tolerated drug for over 2 years is very appealing to me to consider moving alectinib to the frontline setting. I do think that alectinib is likely to get approved in the frontline based on the 2 ALX trials, at least in the United States, which means we'll have 3 options in the frontline space for ALK, crizotinib, alectinib, and ceritinib. And people are going to have to make decisions on which is best suited for their patients based on many of the factors that we discussed before. What I want to talk about is the 4th drug in this space, brigatinib, which is now approved for second-line therapy of ALK-positive disease. Marina, I know you've been part of some of these trials. Share with us the data with brigatinib and how this fits into the landscape.
So brigatinib is another very interesting drug because the results coming from the ALTA trial suggest that there is a very long progression-free survival in further and in advanced lines. And the drug was developed with the 2 dosage, so you have to start with 80 milligrams and then move to 180 milligrams, and the drug is very well tolerated. However, you must be very careful because there is a particular toxicity appearing just in the first 5 days, 3-5 days of the drug, which is the pulmonary toxicity. And I can tell you that I did a chest X-rays to a patient after 2 days, and she had the pneumonitis from this kind of drug. So if you can skip the first days and you do not have toxicity, then the drug is well tolerated and you can give it continuously for a long period. I don't know which is the right place to put brigatinib now in the marathon of ALK inhibitors, but for certainly it is a drug active and with a very good performance status, progression-free survival.
Sure. So thank you for bringing that pulmonary issue because while it is problematic when it occurs, the incidence is fairly low at less than 5%. Obviously, that's the reason to start the drug at a 90 milligram dose for the first week. Once you get through that period where the patients are at risk, you can go up to the 180. The median PFS reported with brigatinib in the second-line space is close to 13 months, which is a number we've not seen with some of the other ALK inhibitors in that space. And to me, that makes this a valuable drug in this situation. Obviously, understanding the mechanisms of resistance and using the right drug to treat the mechanism is an ideal situation, but we're not there yet, Benjamin.
Well, because you are referring to a very nice second-line PFS, but it's second-line post-crizo. And you are promoting alectinib as a standard of care first line. So what will be the activity of brigatinib post-alectinib? This is really the question.
Yes.
And in the paper on resistance mechanism, it's really striking to see that post-crizotinib, you have 10% aggressive resistant mutation. When you are post-brigatinib, it's up to almost 70%. That's why when we talk about sequence, we have to take in account that when you give a strong drug up front, you probably select a more aggressive disease at progression. And that's why really overall survival data will be important. If you are treating a staphylococcus, for example, that is wild type, you don't use the last generation antibiotics. You use the first generation, and when it recurs, you do the antibiogram and you adapt. I think that it's still a good strategy. And I don't promote crizotinib as a first line, but in the ALX trial, there is a figure in the supplementary material that is really, really striking, in which you show that if you take out the brain mets, the activity on all the other sites is exactly similar between both drugs. And in ALX, RMI was done each 2 months. I would like to know if the audience really think that this is a standard of care to perform a brain RMI each 2 months. So it's easy to say that I have a long PFS and look, the competitor is weak because I have obsessively looked at new brain mets, and there is a new brain met, it's an event, it's a 5 millimeter brain met, asymptomatic, but it's an event. That's why the alectinib data are very, very nice, but I think sometimes we rush into new strategies without good knowledge about which is really the best sequence for these patients that live, again, a very, very long time.
Thank you. Now, let's talk about some of the promising upcoming drugs for some of the rare mutations. And I want to wrap up this ALK discussion talking about lorlatinib, which is not approved, but has shown activity in some of the rare mutations. Giorgio, what are your thoughts on what you've seen with lorlatinib so far?
We got an original presentation a few months ago that has been presented, if I remember correctly, at ASCO about this new treatment opportunity. The study has been presented in patients heavily pretreated, and the waterfall plot that they showed in the context of a, let me ask it, a refractory disease, where it was quite exciting for a clinician. At this meeting, there is, I believe, a poster discussion about the activity of lorlatinib in ROS1 translocated patients. Personally, I have only a few patients that have been treated with lorlatinib, so it's mainly based on a gut feeling that a systematical assessment of the activity. So consequently, I make my judgment on what I saw at the presentation. It's an active agent with a toxicity profile that is not so relevant, so important. The agent has the possibility to move to early phases, but again, I share the opinion with Benjamin. We need to be careful in the way in which we are moving all these agents in front line or in the early lines of treatment, because the primary aim, again, as I said before, is to make this type of disease a chronic disease. In addition to that, I see biological differences between the ALK translocated non-small cell lung cancer and the EGFR mutated non-small cell lung cancer. So when the disease is becoming truly refractory to the currently available targeted therapies, it's a rapidly progressive disease. It's a rapidly metastasizing disease. And consequently, the rational use of sequencing, I can agree that 1 year from now we can meet for this kind of educational activity, and all of us will agree that alectinib is the best choice, based on the growing evidence and about the maturity of the data and so on. But to use the right sequencing of the drug through in a pure clinical way, in pure empirical way, or through the guide of rebiopsies, if we want to make this disease a chronic disease, we need to use this kind of approach.